I'm Professor Christophe Leclercq from Rennes University in France, and I will discuss the result of the MORE-CRT MultiPoint pacing trial. The MPP device is a pacemaker or defibrillator which provide what we call biventricular pacing. We have a lead in the right ventricle, a lead in the right atrium in case of sinus rhythm, and a lead into the coronary sinus. Classically, we have only one pacing site in the coronary sinus to pace the left ventricle. With MPP, we have two pacing sites in the same vein. So this provides a better left ventricular activation. The MORE-CRT MPP trial was designed to assess if multipoint pacing can improve the rate of conversion from non-responders to responder patients in a population who did not respond to conventional CRT, biventricular pacing. As you know, about 40% of the patients do not respond on CRT using biventricular pacing, and so we want to assess if to provide MPP pacing may convert this patient to the responder population. So at the end of the trial, we included about 4,000 patients, and they were paced with biventricular pacing during 6 months. At 6 months, we performed a new echocardiography, and we split the population in two groups. The responder patient, we had a decrease in left ventricular and systolic volume more than 15%, and the non-responder patient with a decrease in left ventricular and systolic volume less than 15%. And we kept only the non-responders, and the responders were randomized in two groups, MPP or biventricular pacing for the next 6 months, and then we do another echo to see if the proportion of patients who became responders. The key finding of the trial is that MPP does not improve the conversion rate as compared to biventricular pacing based on an echo criteria. But as we know, there is some discrepancy between echo response and clinical response. So this sub-study was designed to assess if the patients who are not responder with BIV pacing can improve significantly in terms of reduction of heart failure hospitalization or deaths. The main result was that we have a significant reduction with MPP by 37% in the combined endpoint, mainly driven by the decrease in heart failure hospitalization for heart failure, but no difference in mortality. Key take-home message is that in patients who are non-responders, you have to do everything you can to make them responders. It could be improving drug therapy, but also to tune the device as much as possible, and MPP one of the solutions. What we found interestingly in this trial is that, for example, ischemic patients had a more important benefit with MPP as compared to non-ischemic, but also patients with wide QRS and patients with a very long intraventricular delay between the right ventricle and the left ventricle. So I think this is a very important message. Don't give up when you have a non-responder patients. I think that in this field, we have to keep on working about new algorithm to provide a better synchronization. And as you know, there is a very important attraction about a new pacing mode, what we call conduction system pacing, by pacing the left bundle branch block area. And this could be also a very important source of research by comparing biventricular pacing versus CSP. Today we don't have a strong evidence for CSP, but I think we have to move forward for that.